We're the hydradenitis super divas. If you've got HS, you'll want to meet us. It's not your fault, put the shame to a halt. HS divas know how to have a ball. The hydradenitis super divas. Put the shame to a halt, cause it's not your fault.
Hey guys, it's Brinley with the Hydradenitis Super Divas. Thank you for joining us for this episode of Season 2. Just a heads up, if you are watching on YouTube, you will not see any video of the hosts. Unfortunately, the recording was stuck on time-lapse, which is not super helpful. So we do have all of the video of the guest who was on Zoom. That's perfect. If you're not watching on YouTube, this has zero bearing on you at all. Everything will still run just as it should. So just a heads up that, again, we won't have any video of the host, but we hope you enjoy the episode. Thanks. Hi, everyone, and welcome to this episode of the Hydradenitis Super Divas podcast. I'm here with Mahala and Sid, and today we have a special guest on, Dr. Stephanie Goldberg. I'm sure most of you have heard her name in the HS community. She is an amazing HS surgeon. She is at Mary Washington is it DC?
Fredericksburg, Virginia.
Okay. It's like everything in that area all belongs to DC to me. So
it's
that
close
area.
enough. It's about 45 minutes south of Washington, DC.
Okay, perfect. Thank you for clarifying that. So Dr. Goldberg, thank you so much for being here. Welcome. We have so many questions about surgery. And Sid has specific questions about her surgery and or potential surgery. And we just kind of want to cover the different options that happen in HS, when you would be eligible for surgery, when you should consider it, those kinds of things. So we'll just shoot some questions off as we're going. Sid, do you want to start with yours?
Yeah. So I think my first question is just basically what do you do? What's the craziness you see on the day-to-day when it comes to HS? And kind of like a 3-shot question when you recommend surgery to people that have HS.
Sure. And actually, Sid, I just got distracted for a second because I'm looking at the picture that you sent me of your bottom. and actually, it's really helpful because when we do talk about this, I'll be able to explain a little bit about how HS presents so differently in so many people, that there's not one standard approach to how we go about talking about surgery for HS. So let's start with the basics. To some extent, everybody is a candidate for surgery. And what I mean by that is that when we talk about surgery for HS, there's the minimal all the way to the more extensive surgeries. Some surgery is done, they're more procedural based in the office by dermatologists or dermatologic surgeons. And some are more extensive, done in the operating room setting with people asleep. And those are done by a wide variety of different types of physicians and surgeons. So what's most important is to start asking the question of, who knows HS surgery? Who can I trust in my area to do HS surgery or guide me in the right direction? Because, and the reason the caveat here is that what's traditionally thought of as HS surgery in the surgical world is not at all what it is today. Okay. And what I mean by that is, if you look back, I think it was to the 40s or 50s, HS surgery was, there was one surgery. It was called the Pollock procedure. And it basically involved removing all of the sweat glands from underneath the arms and closing it. And that's been the standard of care. So when people started presenting with HS in other areas, the surgical community was really, really confused because they didn't realize that it affected other areas other than underneath the armpits. And on top of that, when you look at the studies from that armpit surgery, they're not very good. And what I mean by that, there's reasons that they're not very good. And that only represents one variation of one technique that you can use. So if you're on the fence about surgery, if you don't know about surgery, keep an open mind and arm yourself with the information, ask the right questions, because there's typically some procedure or technique that can help you in some way.
Yeah, and I think that's a really good thing that keep an open mind. I went into my wide excision surgery thinking, and we had talked about this before on an article, or not an article, but an interview that we had done. I was like, there's no way I can keep my arms up for 6 months to heal. And, you have all these misconceptions about surgery.
Yeah.
And then when I learned like, oh, I don't have to, and oh, I can, have both of these done at the same time. And I had the proper wound care and help with that, because if I didn't have somebody to help me after surgery, it would not have gone well. But yeah, it's definitely keep an open mind, because I never thought I was going to have surgery. That was never on the table for me. It wasn't an option. I was, mom of a younger kid at that point. And then I was like, oh, I can do this. And it was actually making a decision that was so good for myself in the long run. But keeping an open mind is so important, because there are littler procedures that can be done. Not everything has to be a wide excision. You can have smaller procedures and work up to that, or you can do it piece by piece. There's so many different ways to do it.
I also think it's amazing knowing we have a HS specialist surgeon we can go to. When I was having my surgeries, it was just a dermatologist recommending a surgeon and them not being specific to HS. So I didn't have some of the best experiences. But, surgery and all this is such a long process. So it's worth even traveling to a HS specialist. It really is, someone to properly care about that. So that's amazing.
Well, it's interesting. I ended up in this field by almost by happenstance, so to speak. This isn't a hot, exciting area for a lot of surgeons, and I mean that with no disrespect whatsoever. I always had an interest in wounds. In fact, I did research in wound healing during my training, and frankly, I started doing these because when I started as a full practicing surgeon, my senior partners were sending me these cases. They said, oh, we want to do the other stuff here. You're not busy yet. Start with these. I kept saying, what do I do? I don't think what we were trained is accurate. And over the course of many years, I found a community of people, predominantly dermatologists, who were really, really passionate about HS and taught me how things are not what's taught in surgery training. And in fact, Dr. Steve Dave Louie from Michigan, and I partnered this year, and we rewrote the general surgery residency curriculum for the residents. So, and literally had to remove sweat glands. The whole concept that this was an infectious sweat gland disease from
Thank you.
Wait, I feel like me and Brinley are always debating this. Can you actually remove your sweat glands? No, right? Okay, that's what we thought.
But it's confusing to people. And that's what, a lot of times, and I do talk about this is a primary hair follicle disease, but oftentimes I'll get a message from someone after surgery or even before surgery saying, hey, so-and-so asked, are you going to take out my sweat glands? And, I have to explain to them, yes, they're going to come out. However, the intent of the surgery is not necessarily to remove them. They're coming out with everything else underneath the armpits.
Yeah,
because we hear that all the time. Someone's like, I had a sweat gland removal surgery, and we're like,
it's antiquated, right? It's the old information. And I think in some cases, maybe that's how they, I don't want to say dumb it down, but like make it more palatable for people or easier to understand is by using that language. But then what happens in the community is it creates so much confusion. So,
and it's even more confusing because if we call it a hair follicle disease, there's all different types of hair follicles that we have throughout our whole body. I'm certainly not an expert in those. So, but the logical question is, well, if it's a hair follicle disease, why am I not getting it in other areas as well? My scalp, things like that. So
don't wish for it. Don't speak it into existence.
No, I'm sorry.
No, I just mean realistically for me, looking back at my HS journey, it's almost like it was all happening so fast. Like it was in my thighs, and then next thing you know, like it was in my underarms, and then next thing you know, like it was on the lower abdomen. Next thing you know, like it was taking over my butt cheeks. So I'm like, don't be like, oh, well, if it's not over, if it's a hair follicle disease, why is it not bothering over here? I'm like, you literally speak that shit up. Cause like, it seems like it comes so fast out of nowhere. I'm like, genuinely 5 years ago, my butt didn't look like that.
Yeah.
Mhm.
And like, here we are 5 years later, and like every day I wake up and I'm like counting these marks. So like, is there a new spot? Like, because it is that fast.
Yeah,
It
it
is,
can
and
be
it's
for sure.
Yeah.
no, and it's really confusing. I know we've narrowed it down to a primary hair follicle disease, but I still think we're just really skimming the surface of understanding the pathogenesis of it, what's going on. And I think with all the enthusiasm in the field, I have so much hope, not to sound cheesy, and excitement for the future of HS. And I think right now we're on the right track. It's fascinating to me to think about how many diseases are influenced by inflammation, and how many factors come into inflammation in all of our daily lives. So I think we are really approaching this in a positive way by really focusing on how do we decrease inflammatory response and inflammatory burden.
Yeah, I always say the same thing when you were like, oh, I don't want to sound cheesy, but I'm always like, okay, it's never a good time to have HS, but if you have to, like right now is a really good time because we're, finally getting our chance to be in the spotlight. And that is so refreshing, I think, for so many of us that have suffered for so long with no options really. So it is a really good time, and it is a very exciting time for us to have so much happening on the HS forefront. So I love it.
So what are the indicators you're looking for as a surgeon when you're like, this person with HS should have surgery?
So that's actually a nice segue, and a thought that I had a second ago, Brinley, something that you said, and I will come back to your question, is that I'm seeing more and more people present who've been suffering in silence with this disease for so many years, either because they are embarrassed or don't feel that there's anything that can be done, or they just thought it was too mild, so to speak, and that they wouldn't be a surgical candidate, which is also old news, or fake news, if you want to call it that. And those people, there's a lot we can do for them, but it's definitely much harder, much more extensive, and the recovery is harder. And as a result, the cosmesis, how it looks is also going to be different. So just kind of keep that in mind. And that's a segue into what you were asking, is when is someone ready for surgery? So as a field, we need, and I've been trying to advocate for this as much as I can, we need to stop thinking of HS as a cancer in how we treat it medically. So what I mean by that is in cancer, our goal is the focus is, can we cut it out and or treat it with other medications to prevent it from coming back, especially if it's localized to a small area? So the difference between cancer that hasn't spread and HS is that HS is more of a systemic inflammatory disease. So as much as we see it on the skin in an area, what I have to remind people is that there's all these changes going on deep within inside your body that you can't see. And these spots are only a small manifestation of what's going on in your body. So with that in mind, surgery's gotten a bad reputation because when it's been done over the years, the focus has been, how do we cut it out and make it not come back? And that's actually, we can certainly talk, we'll talk about that shortly. But instead, what I like to focus is, what are your goals? What are your goals of potentially surgery, and what are you looking for in life? Like if I could, I'd love to wave a magic wand and make it go away, but I can't. There are some cases where, and it's not 100%, of course, but there are some cases where I feel comfortable that we can have a better response, if that makes sense. And there's a good chance it won't come back in that area. But I never make any guarantees for that. So going to that theme, what I like to talk about is it the pain? Is it the drainage? Is it any odors that you have coming with it? Is it your inability to work or to play with your children or your family? Is it intimacy driven? Where does this fall into play? And based on that, let's talk about what we can and can't do.
Okay, so someone like me and Sid right now who have stage 2 and 3, what are our surgery options? Like,
Okay.
I don't even know where to start. Yeah, what are our options? I have it
So-
severely under my breast. She has it, I guess, severely on your butt.
Everywhere.
Other places.
And
Yeah.
my underarms are the only thing that are doing real good right now.
Yes. So what
So
are our options? Yeah.
So the answer to that question is it's not a one size fits all option.
Yeah.
And Sid, I looked at your beautiful butt with the picture that you showed me, and you did say it's all over social media. So I assume I can share what I see.
Yes.
Yeah. And we'll post the picture on the podcast too, so that people can see it as well if they haven't seen it.
So of course, there's even a flower there.
Yeah, it was part of our Beautify HS project. That was the
I recognize the color and that, yes, I do. And Brindley, I actually showed someone the website with your beautiful pictures on it the other day when they told me how uncomfortable they were with their HS.
Thank you for doing that. Yeah,
That's what we wanted out of this project. Yeah. We wanted to showcase what it looks like, like what there's so many people with it. So
yeah.
Oh.
And how we're still beautiful. Like
Yeah.
it's part of who we are, and we have to accept that. And that's the only way we can raise awareness too, is by showing people and helping other people stop being so shamed by it. So thank you for doing that.
Yes.
You're welcome. Okay, so we talked about surgery. And who's a surgical or what kind of surgery would be most appropriate. Before we go there, can we come back to the medical piece? Because the medical piece is going to influence how it looks and how it's behaving, how the tunnels or the lesions look when I look at them are going to influence which procedure we're going to do. So most of the time, so I get a number of different people who come to me. Some have never seen a dermatologist. Some have seen a dermatologist and are optimized as best they can with the medicine. And others have stopped the medicine because they've said, well, the medicine isn't working. And it's interesting because what I have to remind people is that it may not be that the medicine is necessarily not working. It's that, what is your goal from the medicine? And they'll say, well, to make it go away. Well, we have great drugs now. We're so fortunate to have great medications that can help treat this. However, it's not going to make it go away in most cases. It's going to help control it. And that being said, when I look at people and you come in for an evaluation, there's some folks that I can tell based on how the gross pathology, what I'm seeing, being on medication may help do a smaller operation, okay, by helping control the surrounding inflammation. Whereas some people, I might look at it and say, I'm not convinced the medication is going to make a tremendous difference long term in what we have to do. I think medication may be of value to you, but let's do this side by side and concomitantly. So let's start by talking for how we decide what surgeries we do. There's a couple other factors that I like to bring into this. And I am sorry if I'm confusing things even more. Okay.
No.
So the next big question I have is, what do you do for work? And who lives with you? And the reason is, what do you do for work? Well, the reality is that most of us can't afford to take time off for medical conditions, both personally or professionally. And many people have small kids or elderly parents who they're caring for. It may be a single parent home. So we may have to shift our options and our expectations. It doesn't mean we can't help you and we can't do surgery. It just means we might take a slightly different approach to make sure that the rest of your life is stable and still functioning the way you need it to during this time. And perhaps you have someone at home who can help you. Perhaps we have to bring someone in, or a friend who you might feel comfortable confiding in, who can help you with this. For the after surgery care, I used to use home health a lot. And now I rarely use it. If someone really wants it, I will. But the challenges are, I do like everyday care. And believe it or not, home health nurses are fantastic, but they also don't have experience with these wounds. So a lot of time when they see them, they panic. And especially the big ones, it's a lot. Whereas you all, as people who have been living this life for so long, to you, you're like, all right, I got this. I see where this is going. I see the light at the end of the tunnel. I'm gonna get there. So let me pause there and see if you have any questions about that before I keep going.
So do you prefer that people with HS who have gone surgery kind of find that person for them who's willing kind of to like be in house, help with that? I think you're saying that having a nurse that's kind of like scared or amazed by your wound would kind of like burden the patient a little bit, like, oh my gosh, it's too much for her, like,
Yes. Well, it creates panic among
yeah.
the people, the patients. And I had a patient the other day actually who we did arrange for home health. I'm not violating any HIPAA by sharing the situation, but we did arrange for home health, and the home health nurse saw it and was concerned because they hadn't seen anything like it before. And it was less than a week after surgery. It was an open wound. So she sent them to the urgent care, and the urgent care people there had never, weren't familiar with this. So then they sent to the ER, and then the ER directly admitted the patient. So I got a call from one of the hospitalists who said, hey, what's going on? I think it looks okay. I'm really confused. Well, it looked completely and utterly normal. There's no infection. It's at the appropriate stages of wound healing. And I just said to that person, I am so sorry. Of course, I have my folks send me pictures all the time, especially afar, so I can, if they live afar, so that we can monitor the wounds, and I can keep a close eye on it. So but having that added layer of panic, and it's a lot, and there's a financial cost to it for people as well, a time, a disruption of the life.
Wow, I think
So
that goes to show how much work is still to be done in those medical places, like in the urgent care, in the ER, because all it really kind of would have took was like one person like, hey, this could be HS, and it just shows how much work you all are doing, and that it still needs to be done.
And I found too, like, as a person healing from a wound like that, we're used to wounds, right? But not necessarily like a wide excision wound.
no.
Or like, a CO2 wound or anything like that. So I know as a patient, it was so helpful to have like what that wound healing process looks like. Like in the beginning, we always called it red and meaty. You want it to be red, meaty, like ground beef. That's good. Like that's a good thing. So
That's
every
a good
day,
thing.
yeah, I was like, Mom, does it look like it's red and meaty? And she's like, yeah, we're getting there, And so just knowing kind of what you're looking for, it also helps you as a patient to have that knowledge and information, because it makes you less fearful of the process. And the other thing I really appreciated too is that my surgeon took photos on the operating table and showed my mom what this looks like.
And then we showed social media, and
Right.
so many people were like, thank you for sharing this, because it's the real and rawness of what happens after surgery versus like, hey, I'm 3 weeks post-op, I'm feeling good. Like, no, we want to see what that process looked like up close. And for me, it's been so eye-opening. Even just watching Brinley's surgeries this year, I'm like, one, I know that I could do it because she's a little too strong, but I'm like, if she could do it, I could do it. And then I'm like, just to be able to watch the process, she's definitely let us see what the process has been like from start to where she is. She's still not finished, but that's also just reality of like getting a pilonidal cyst excision, you know, like you're not going to be healed in 2 months. It's a 4-month, maybe 6-month process. And she's not sugarcoating it because she just wants to make all of these doctors that she works with super, super happy and like, hey, everybody's getting surgery now. She's being extremely transparent. And I mean, that's what we need in the community.
And it does help your wound care person too, because like, you know, we leave the hospital or the surgery center and you're covered up, right? Yep. So then they have no idea what the hell to expect when you get home. And when they take that off and you're like, okay, kind of looks like a shark attacked you. And you know, like this, people haven't seen wounds like that before, especially left open.
And they're all different, you know, they're all different. Whether it's down to the flesh, if you're doing an excision and keeping it open versus the complex deroofings that I certainly specialize in, where it's kind of like a bumpy, pebbly type of bottom of almost like if you're walking on pebbles in a lake or something. Yeah. That's kind of, you know, with little hard spots here or there, which often is scar or that, you know, epithelial lining. You know, what I typically do is we look at pictures in the office before surgery of people without any identifying information who've given me permission to share. We also, so I take before pictures in the operating room directly into the chart. Then I take after pictures. And then if it's something that's really confusing in terms of how to do the wound care, I do have videos that I show my patients and their families on how to do the wound care, but I might show them another one specifically, you know, from the operating room so they know what to do. And then I go out into the waiting area. We go into a little conference room and we review all of these things. Mm-hmm. And honestly, the fun part, look, it's a hard process. The healing process is hard for a number of different reasons. It's not impossible, but especially for the big wounds, it's so rewarding to see to be at the end and then to look back at the beginning and say, oh my gosh, look how far you've come.
Because and they start out huge and they end up so much smaller.
It's like, insane, isn't it?
I was floored at how big it started and then how small it ended. I was like, there's no way that turned into that. So yeah, it's fascinating.
No, and everyone does heal differently. Mm-hmm. Trying to think where we are now. Okay, different people. All right, so let's talk. We've talked about all those things that I ask and all those questions that I ask. That really lays the foundation to give me a framework in my head of what is the best procedure for you and or what procedure, depending on your goals, will be best with your current life. Okay. And I'm gonna
you could totally use me as an example if you want to. Like if you want to use my butt, and then I also have children who are tiny and I don't have the best support system. So what treatment option would you recommend for me like at this time?
So for you, and so your disease is there's a couple of different patterns that I see, okay, of how the disease presents itself. So that also comes into play. And just humor me for a second. For example, underneath the armpits, it's kind of typically centralized to that area. Although in some people, you might have some lesions below, it might extend over to the breast, and some people it doesn't. Similarly, on the back side, some people have long tunnels that form that even go deep. It traditionally wasn't thought to be a deep disease, but it can go deep. And other people have kind of scattered areas, okay? So Sid, you fall into, from what I can tell, on your right buttock, more of the scattered areas. Some of them probably connect. It's hard to tell. And if some of them, even if they don't connect, and what I mean by I can't necessarily put in a probe and connect it from one to one, or one area to another area, there's some areas where I can see that you still have skin changes overlying that area, suggesting that there's some disease present in there. Okay. So that's where the art of this comes into play, because as I go about this, we have to make some decisions for you about what are your goals from this? And what's the best option for giving you the best chance? I'm looking at your left buttock right now, and I actually don't have a good view of all of it, but it looks to me like there's more areas that are a bit more coalesced, and which are going to be more well formed, if that makes sense, underneath the skin. So that may be easier for me to navigate surgically and minimize the chance of it coming back. So as much as I just told you all that, I don't like to talk about, recurrence. Well, we have to talk about recurrence because that's, even though we can set our goals, recurrence is a big issue. My hope is that if it does come back, and we're actually working to change it to not quite about recurrence, but persistence in the field. But if you notice it coming back in that area or persisting in that area, hopefully it can be controlled with either medication and or a much smaller procedure than you had before, rather than that big giant procedure. So going with that theme, for you, based on what I'm looking at, and I'm actually just can I hold up my phone for fun?
Yeah.
Nope, it won't work. Okay. I'll just have
we'll have to insert it.
Yeah, that's fine. But I can't see what's more medial between, closer to your anorectal area, but on the actual butt cheek itself, I'd probably take an approach which I call cherry picking. Okay. So, but before I do that, what's your goals? What would be your goal for, let's talk about your right buttock.
So I know you can't see, in that picture was probably what, like 5-6 months ago. So I have had about like 6 to 10 reoccurrences, like get big and inflammatory and angry. Since the Beautify HS project, my butt is really my troubled area right now. So it probably looks a little bit worse if I'm just being fully transparent. And so my goal would be to obviously like try to reduce the angry guys, right? Because it seems like a lot of them are they get angry, they die down a little bit, they come back, and I'm not really much seeing a lot of like new bump, new area, new scar. It's kind of like just repeating itself a little bit. And then it's that crest that it's literally like the butt crack, like where you wipe, is really kind of like brutally affected. So I think I just want to be able to sit for a little bit longer of time without that stinging coming about. And then I also have a pilonidal cyst as well. So just want a better quality of sitting life.
And I think the important thing too for you that you've mentioned is like the shape of your butt. That
I'm like, it's the one thing I got going for me, doc. Like it's nice with some leggings on.
You have a beautiful butt. Okay?
We all let her know all the time.
Want a butt like this. So for the right buttock on the more curvy part of the butt, what I would do is do like a cherry picking, like you were talking about. They're those same areas that bother you over and over again. You have disease throughout that whole buttock, but what we would do is almost core out those areas. I would do complex or deroofings, so to speak, of all of those little lesions, clean out that gelatinous material inside and help promote it to heal. And so when you'd finish surgery, you'd look like you have a bunch of dots all over your
nothing new.
just a different kind of, and it may be that some of them connect, it may be that some of them don't connect. So you may have this weird pattern of things as well. It kind of just depends on what I find when I go underneath the skin. But we would we would make that decision together in the preoperative area to the best that we can, and we would circle those areas that are most affecting you. I can't see the butt crack here. However, what you're describing seems very classic for a lot of deep, complex tunnels that kind of go off in all different directions. So, and I do find they tend to be a bit more deeper there. When I say deeper, what that means is that they're if you think of someone's meat per se, of their subcutaneous tissue, and this is the surface, it may not just be here, it may go a little deeper down there.
Okay.
But the way we avoid ruining or losing that contour that you had, what gives you the contour to your backside is the fatty tissue, is the subcutaneous tissue. So we leave the subcutaneous tissue. We just focus on the lesions themselves, and they heal from the bottom up, and they heal up beautifully. But I would suspect that the inside area would be a lot deeper, and because of that, it would take a lot longer to heal. And that's so. That being said, you had asked, you are a single parent home, you have young children. What would we do? Well, we would probably do it in a staged fashion at a surgery center. Unless we could easily do some of them in the office, but we can do more with you comfortable and asleep. And we do one buttock, likely followed by another buttock. Again, it depends on what I see. The little spots that we're talking about, I think in a couple of days, you'll feel great. A bigger one is another story, and that may take some time, and it's going to take someone who can come and help you with your wound care until it gets to this place that Brinley was talking about, where you have that ground meat color tissue, and it's the wound is basically, if it was deep, has filled to the surface, and it's just kind of, it's at skin level, and now you're just waiting for it to close. Once it gets to that point, it's almost on autopilot. So you can easily do that yourself, for the most part, by looking in a mirror, because it's just a matter of laying a dressing on top, and you don't have to nurture it as much.
Yeah, as soon as it, and this is something I had learned with wound care too, is like, as soon as it comes up to the surface, like your skin can't heal over like a crevice. So once it comes up to the surface, then your skin just like, oh, okay, we're going to meet in the middle. And it's amazing to watch that process happen. And the other thing that do you recommend wound care usually for people, or how do you, like, I know I always recommend, or I always request wound care, because it makes me feel so much better to have somebody keeping an eye on it, and somebody's like giving me kudos for what my body's doing naturally, and I'm taking all the credit for it.
So are you talking about a home health wound care nurse to come in, or
so
at a wound care center?
I go to a wound care center, and I go like once a week. But they've also provided some products that I like never knew existed that have really helped expedite the healing, especially when I've had really deep wounds, to help bring them up to the surface faster, so that healing can be expedited.
That's fantastic. And there's a lot of different techniques that we can use to help expedite that healing. I use wound care centers sporadically. If someone wants one, absolutely, no problem. Some people really don't need it. The best way I found that I can use them is that if the wounds I feel like they're stalling a bit, or they're not quite healing in the way I'd hope them healing, I use the wound care center to get the wounds where they need to be. And what I mean by that is, you can develop, as the wound's trying to heal, you can develop this layer of, it's basically fibrin that your body makes. It's like a fibrinous debris that lays on the surface. It's a whitish layer. Sometimes, if it's not densely adherent, you can and you're not in pain, you can wipe it off. But sometimes it can be painful. And they have a lot more products available to them, and devices. They have irrigators and things like that they can use. So it just depends. And by the same token, actually, I have a lovely patient right now who I don't think his family would mind me, or I know they won't mind me sharing this, but he, like you were saying, Brinley, just likes to go to the wound care center. And he does well with it, and they know him well. And he an older gentleman, he enjoys that interaction. So he goes Monday, Wednesday, Friday, and it works for him. And the family does the wound care on Tuesdays and Thursdays, and everybody's happy.
Yeah.
So, I think it's not a one size fits all model. And that's important to remember. The other thing I just want to touch on for a second is, and you guys can kind of take the reins with this, is pain after surgery.
I was just going to mention that actually, because I've found in my experiences that the first week can be somewhat rough. But after that, and I think a lot of it has to do with apprehension and like anxiety about changing and things like that, because you're anticipating pain.
Yeah.
But I found even wide excisions are far less painful than a really bad flare. Like I would take that, and that's my personal experience. I know other people have completely different experiences with it, but I think that, you know, we deal with pain on a daily for the most part. So for us, we're a little bit more accustomed to it than somebody who never deals with pain. But I've found that for me, the experience has been that it's not as bad as a really bad flare.
I don't understand pain, and nobody understands pain right now. And I think that's part of the problem. So there's a couple of things, observations that I've made over the years, and I'm actually in the process of rethinking my approach towards, you know, post-operative pain management. You know, the hard part about post-operative pain management is that the opioid epidemic, and you can, you know, watch all the TV shows about that, has really put physicians in a really tough situation right now, where we are monitored so closely. We have to justify things. We get flagged. And it puts us in this situation of how do we advocate and care for our patients and give them what they need. So that we just have to be very cautious and careful and document and see things and so forth. So that's kind of one of the challenges on a clinician side. That being said, pain is multifactorial. And Brinley, I love how you brought that up. You know, there's a physiologic component to it. I wouldn't be surprised if there's a genetic component to it, but I haven't looked into that. But then there's also a psychological component to it. And it's all of those different factors that come into play. And, you know, panic and hysteria, or just kind of like, oh my gosh, what's going on here, is a totally normal response to surgery, or a normal response to someone else seeing what was just done to you, who cares about you so greatly. And I think that can contribute it too. So what I like to tell people is that with any, you're going to have, we'll come back to this too, but for the most part with surgery, you're going to have some pain after surgery. The goal is to get it down to something where you can say, I know it's there and it's not pleasant for the first couple of weeks, but I can tolerate it.
Discomfort.
You know? And the next piece of that is that pain can be throbbing, it can be stinging, it can be burning. There's so many different types of pain, and there are some better medications for different types of pain. But what I find is that there's a lot of people who, when we talk about the pain scale, like 0 to 10, they can't fathom what a middle
1 or 10.
Yeah, exactly. Or zero,
Yeah.
0 or 10. So, you know, that's very challenging too. And then there's also that component of wanting to get up and do everything. And I'm a huge fan. I don't really give restrictions after surgery. And nor do I keep people in the hospital anymore after surgery. That to me is a thing of the past. And there's a couple of reasons for that, including that most insurance companies won't cover you to stay in the hospital as well. But I don't think you need it, and we don't do it in a way that you need it, because we want you to get back to your lives, and we don't want you sitting around and getting blood clots or other things like that. But there's also that balance of doing too much versus getting going and taking that time. So in general, when people ask me how long it's going to take to heal from this, I give them a range of their wound, which is approximate depending on the rough size. Everybody is different. But the reality is then there's that, what about till I'm back functioning? And back functioning, if it's a big wound, we're probably talking about anywhere from 3 to 6 weeks. The first 3 weeks can be rough. That being said, I have some folks who, you know, need to get back to work, and I don't know how they do it, but they, in a week, they muster through it. They're back to work, and they just make it happen. So going back to you, Sid, if we were just talking about that right butt cheek so far that I could see, those areas, you'd probably be back to work in a couple of days. hypothetically speaking.
That's super relieving for me. I think a big fear for mine surgery wise was like, I don't want it to be this big thing. I can't be down for too long. And then also I am a recovering addict. So like pain management has been a huge fear of mine because I'm like, I don't even like hardly ever even pop an Advil because of like previous life decisions. Right. So I'm like, I don't need to be like prescribed oxy, and like it just totally is a fear of mine. And I'm like, if it's a fear for mine, I can only imagine who else in the community has battled addiction, and like that's a genuine fear for them as well. So that makes me feel really, really good just having this conversation, knowing that like my life isn't going to be over, my butt cheeks aren't going to be completely ruined. She's actually wants to help in the best interest without making it super invasive, not only to my body but to my everyday life. So I mean, that's this really cool.
Well, and I think you have the right attitude, so I think you're going to do well with this, because if you have the right mindset going in, you can, ice is a great adjuvant. I poo-poo ice, a sprained ankle, put some ice on it. I'm not putting ice on it. It works. It works. It numbs the area. The receptors that the cold trigger. You feel that, and it numbs the area, and it can really, really help. Advil and Tylenol can help. They're not going to take away the pain for the most part, but they can help. Same thing, keep it at bay. And actually, I've been using a slightly different local anesthesia mixture, which seems to last a little longer. And I'm noticing my patients are not really having pain for a couple days after surgery. So that being said, let's talk about the pain and that spectrum of the pain. I have some people, and I kid you not, if I call them the day after surgery or they come into my office, like even like that week or within a week or so, they're like, look, I can move my arm and it doesn't hurt at all. And they're touching and it's shocking. And, for them, that's actually another thing. When people wake up in the operating room, even if they've had pain medicine, what they say to me is, my HS pain is gone. I have a different kind of pain right now. So I am in pain and I'm having, but it's a different type of pain from my HS pain, which also shows you the impact of the disease and what's going on in the skin on pain. All right. So I have those folks who, again, can move, no issues. You touch it, no big deal. They're like, this is great. I'm off, and so forth. And then I have this group of people who have a very significant pain response. And it's really hard for me to tell and predict who's going to have that and who's not going to have that. And that's where the hard part comes in. And we just need to stay in communication. We need to have an open mind to come up with adjuvants, because the answer, I think you all can appreciate this, the answer can't be, well, let's just keep writing, oxy or something like that. It's, we may need to pull in mindfulness techniques. We may need to pull in the icing, psychological component. And it doesn't mean you don't have pain. The pain is very real. It also may be that the type of pain you have may be managed best by a different type of medication that's not a narcotic. And there's a trial and error period as well to try to figure this out. And it doesn't just take a day. So that's the other hard part. It breaks my heart to see people in pain after surgery. For the most part, I would say that the majority of my patients don't fall into that category. But when they do fall into that category, my heart just aches for them.
It is amazing because and we've talked about this before, you guys, like when you look at the wounds, they look like they should hurt like hell. And when the patient, like when I'm like, it doesn't hurt though. Like, for the first week, you're like, you can't really lift your arms depending on, what you've had done. And every day I was like, okay, a little bit more in the shower till I could wash my own hair. And then I was like, yes, I could wash my own hair. Like as you're going through that first initial phase, but you do look at them and everybody's like, oh my God, how can you be missing that much skin and it doesn't hurt? And you're like, I don't know, but it just doesn't. You know, it's very, very odd, because I expected to have much more pain originally than I did. And then after having that experience, I was like, okay, this is totally manageable. And the functional piece of it too, that you had mentioned, there's a difference between being healed and being like healed enough to be functional. And people, it's a long process to heal depending on how big your wound is. We're talking months, right? To finally close over and be completely healed. But time, you know, until you get to that big and meaty part, and then the skin starts healing over, you may be affected and have to, you know, not do all your ADLs or cut back on some of that. But for the most part, like within a week, I was up doing pretty much everything.
Yeah.
And it's amazing, but you don't, when you look at them, you're like, oh, no, I'd be in bed for 6 weeks. And you're like, no, actually.
Like they're going to send me to a rehabilitation center.
Well, I struggle with pain. I struggle with pain. I've always been, my mom was a nurse and she never struggled with pain. She was always able to get up. So I was always her dramatic daughter. But what you said, Brinley, still, I mean, pain is horrible. Like my sisters make a joke, like, Mahala hits her knee, it's like a week thing. Okay, like pain, and I think some of it's my anxiety. I struggle with the flesh of HS and looking, so I think I see it and it probably causes more fake pain for me. But I'm like, oh, it looks painful, it is painful, you know. But I think you brought up a really good point. For me, although the pain after post surgery, all that has always been bad, but HS is so bad too. For me, the pain has always been worth it after versus living with this reoccurring. So someone who does struggle with pain, it's still to me worth it long term.
Yeah.
Well, and it's, you know, the timing also that you have pain after surgery, if you fall into that category, same thing. It's so hard to tell. I have some folks who, I mean, typically by 3 weeks, you're in a much better position. I had a dear patient the other day who, it had been, the first 2 weeks were awful. I mean, awful. And then I saw her back and she's like, I don't know what happened. Just literally overnight, it was just like, and all of this was very real. Gosh, I was so excited for her. So that's, no, it's hard. It's a hard topic. It's a hard area to manage. And for physicians with our toolboxes, if pain were easy to treat, nobody would be in pain.
Yeah.
And so, you know, that's a tough spot.
I think the mindset thing that you mentioned too is huge. It's absolutely, for me, it's one of like the predicting factors as to what you expect your outcome to be.
Yeah.
And that, you know, I've always said, like, I chose my scars. I didn't get a choice in having HS. That was given to me, but I got to choose this as an option to help myself and to help my HS and to take care of what I could, because we're so limited on options. And I'm like, never thought I would show my armpits to anybody. And now anyone who will look, I'm like, look at these beautiful things, right? Never in the past would I have worn a tank top before having surgery, ever. And so I think having a good mindset about going into it, having realistic expectations. Is it going to hurt? Yep. You just had surgery. Sure is. But knowing that comes to an end, whereas HS pain can be chronic and never ending and new flares daily. Like, you are taking a risk on doing something, but what if that risk pays off?
And
like,
it's something you have control over.
For
like,
me,
it's so nice to hit that almost a finish line.
Yeah.
Like, this is something I finally have control over that I can gear towards.
Yeah.
You know,
and like, for me, that is the answer now. Like, when I have, chronic, irritating areas, which I judge based on like a year, I give it a year. And if it's still bothering me, then I'm like, okay, you got to go.
We're gonna remove you.
Thanks for staying. But like, now surgery is my answer, and I have pretty much gone into remission. I have very infrequent flares now, and I know that it works for me. And if I hadn't just muscled up and done it the first time and been like, you know what, I'm going to take a risk on this, because what do I have to lose, basically? I would never have been in the place that I'm at, and it actually led me to where I am now.
And I think it's super cool that you have had surgery in so many different areas.
Yeah.
Like she's had the wide excision on the groin, she's had the pilonidal cyst excision, and then she's had the under breast, she's had the underarms. I'm
Mom's
like,
pubis.
and from being somebody who was against it from the beginning, I mean, like it's a testimony within its own.
Now I'm like, hey, Dr. Kim, I'm coming in.
Yeah.
Let me send you some photos of what I need done. Yeah.
Well, another thing, Sid, you were talking about that you love your butt, and you have a beautiful butt, but the surgery itself does not have to be disfiguring. And this is, I'm speaking especially to women, for their front parts. There are a number of women out there who, when they historically sought care for this, the treatment that was available to them at the time was a very invasive technique. And there are still some people who really need that depending on their goals. But the thing to know is that there are smaller things that we can do so that we're still preserving those fat pads that give the contour toward your labias, and if I can say that word on a podcast. Yes. You said mons, so I can say it.
Look, we cuss, we do anything we need to say on this podcast. Okay.
I love it. But there are a lot of things we can do, and that's where we have those conversations about goals and say, well, if you're, would you be willing to accept if we leave a little, maybe we leave a little disease behind, but that little disease isn't the main problem for you, and it's manageable, and you still feel confident and comfortable in your own skin. So,
yes, and it's important for patients to speak up about that too, because surgeons, your main job is to like eradicate the disease and help us get rid of whatever you can. But if that is a real concern for you, like as a patient, speak up, voice your concerns, say, this is important to me to keep.
And I think we make them smaller because I only said that to Brinley out of like a jokingly matter. And then she was like, no, I think you're really concerned about this.
Yeah.
She's like, I think this is really going to hold you back. I'm like, probably, girl, I don't know.
That's it for me. I mean, that's my number one concern with my HS. I'm a plus size model. So like, how I look matters, how my scars appear.
That's your job.
It literally matters. Yeah. Honestly, if I wasn't a model, I might not care as much, but because that's my profession, I care. So I also think it's fine to care. I feel like we get so shamed, like it's vain. And that's something I've struggled with HS too. Like, I feel vain. Wouldn't it be better to just not have this? But it's like, I also have to live and have a livelihood. And I also want intimacy and to feel good in the bed. There's so many dynamics. And I'm personally sick of feeling guilty for wanting, my HS already looks like shit. If I fix it, I want it to look the best it can.
Yeah. That's a good point. That's so good.
Yeah.
And I think, I will say, I'm actually going to put a plug out there. Another thing is that in my mind right now, there are women who've been, told that they need mastectomies for breast HS. There are women who have been told that they need to have like radical vulvectomies and have those areas removed. And it doesn't mean that if you had it done, it was the wrong thing. Mm-hmm. Okay, I want to emphasize that, because it, again, going to the theme of at the time when you had it done, where was the field in terms of how we did things, what the accepted techniques are, and so forth. But that is not something that I advocate for. In fact, the only time I would ever consider formally removing even, parts of the labia or the vulva is if there's something called lymphedema that develops, which is basically swelling of that area. And once the tissue gets like that, it's throughout that whole area, and there's really not a lot you can do, which is also a plug that if you start developing lymphedema, definitely go see someone.
What is lymphedema?
Lymphedema is where the lymphatics are affected. And I tend to see it in the setting of longstanding HS in the different areas. For men, I actually see it in the thigh area for some reason or another. And I actually have had a female patient the same. And what I'm talking about, I don't know if you all are familiar with this phenotype, but there's some folks literally on their inner thigh, away from the groin area, they get this area. It's probably about this big or so. And it starts out as like little punctate dots, and then it kind of coalesces into that big area. So I've seen lymphedema there. I've also seen lymphedema in the Mons area in women, even if there's not a lot of active HS there, and the HS is maybe inferior to that or vice versa because of the impact that the HS is having on the lymphatics. So you'll see kind of a bubbling of the skin. It might feel hard and boggy is the best way to put it. Will look very different and feel very different than the skin around it. Wow. And I can get you guys some pictures of that too.
Yeah, and we can put them up on here. That would be amazing.
Yeah. In fact, I can give you some. I have a couple people who have given me permission to share their picture. So we can always use some of those if that would be helpful.
Yeah, that'd be great.
Yeah. Something I've really learned this season on the podcast is a lot of, I think, our HS trauma with doctors or dermatologists, specialists, whatever, is that we're not seeing an HS specialist. I think, and I understand that access may be hard, but I think for me, a lot of my trauma comes, I went to so many dermatologists, so many surgeons, and they knew nothing about HS. So then I got all these procedures done with limited information, and all those procedures, even if it was a financial cost, it would have been so much worth me going to see a specialist.
Yeah.
And I'm realizing the specialists just know more, you know, like every doctor can't know everything. And even speaking to you, I'm like, I think it's something the community has to start being willing to invest in, you know, but I'm looking like all those surgeries would have added up to me just flying out and getting you and doing it correctly right away. So I think that's something we can probably all take towards to.
We're coming to Virginia.
Yeah.
No, honestly,
come into your office.
First, like also Burnley, you've had really good experiences with specialists, and I'm just learning that, like, I think a lot of our trauma is strictly coming from we're seeing a lot of people who just don't know enough about the disease.
Yeah.
I'm like, you don't know? I don't know. Okay.
Yeah.
See you later in 10 years.
Exactly.
HS specialists are great. But you also, not all HS specialists, you know, HS is so different for everybody that it's not a one size fits all model, even with medications. Okay. So, and the surgery is definitely not a one size fits all model. And there's probably a handful of folks, maybe less than that, who are surgeons who truly have experience with HS and in the US. And even then, if you asked all of us, we would probably do it completely differently.
Of course.
So those are other questions that you want to really have that conversation. You really need to be comfortable with your surgeon when you embark on this journey, because it's a lot of trust that you're placing in the surgery. In fact, it's a bit humbling, frankly. And we also need to know that you understand what we can and can't provide. So I actually have I had a patient the other day who said, I feel like you're trying to convince me out of surgery. And I said, no, I'm not trying to convince you out of surgery. I need you to understand what I can and can't do. And I need to feel comfortable that you understand this, and I'm not going to let you down in the process or make you feel unsatisfied. So, you know, that's another thing. When you go to see an HS specialist, you know, make sure it's a good fit for you.
Yes.
Yeah. Really, really important.
Yes. And if it sounds like someone's trying to convince you to not have the surgery, you're probably with the right person.
Yeah.
You know, because it's like, no, I want to know the real about this. People who tell you that they can cure you. And let me tell you, we have seen this all over social media lately. There are a couple of surgeons that I absolutely just want to smack upside the back of their head who are coming out here and like, oh, do you have HS? We can cure you. Bullshit. HS cannot be cured. So those people avoid like the plague because they are making promises they cannot keep.
Yeah.
And
there's also,
that is dangerous.
Brittany, I think it was you who sent me an article to look at about a flap, and it was this novel approach with a flap to cure HS. And when you talk about surgery for HS, it's twofold. Okay. There's the part of how do we remove the burden of disease, all that inflammatory tissue, which is causing the problem and the pain and the drainage and so forth. But then there's the reconstruction piece. And these are two separate things. But so on the reconstruction piece of things, there's a couple different options. One is we close the skin directly. I'm not a huge fan of that. It doesn't mean I won't do it. It's just I'm not most of the time I don't do it. And the reason is when we think about the systemic nature of this disease, the fact that it goes, you do have all those inflammatory changes through the body, you're going to have inflammation in the surrounding skin, whether you can see it or not. On top of that, and that's where actually medication also helps. On top of that, these wounds are more likely to get infected. On top of that, a lot of the areas where you're closing these wounds, there may be tension or a little more tension. And then, all these things, infection, tension, necrotic disease, things like that, or necrotic tissue or dead tissue, so to speak, lack of good blood flow, which doesn't seem to be an issue with HS patients, but all of these things contribute to wounds that you close opening up, okay, after surgery. And the reality is, most of them we see in HS. So we're almost setting ourselves up for at least a 50-50 chance of it breaking down, which is what we saw in the papers from way back when. So I typically let things heal from the inside out. And that's one thing. And I can't believe it. I see these big wounds and they shrink up. Now, they look different on everybody. Mm-hmm. For the most part, they underneath the arm, they tend to shrink up to a line. However, I do have some patients who they stay that size, and we do exercises. I have people do exercises every day with lifting their arm as soon as they can after surgery, to try to keep that range of motion, and or we can do some physical therapy to help. So with the scars that form, they take on a number of different colors. Sometimes they look just like skin, and the same color or pigment is skin. In people of color, I do sometimes see, it just depends. Yeah. Some folks, it's repigmented. Other folks, there may be a little more of a depigmented area. Actually, I see this mostly with men on their buttocks and big lesions. I'll see a rim of pigmented scar followed by an inside area that once it's healed, that is more pinky in color or pale in color. However, they haven't seemed to mind so far because the disease is gone, the pain is gone, and they can sit in that area. So the wound healing is one reconstructive option. And for that, you don't need any kind of reconstructive expert. Mm-hmm. The other thing you can use is a wound vac. Okay. And wound vacs are great. They definitely, they're great for so many different reasons. Okay. They, you carry around a little purse or bag for those of you who don't use purses, with a little machine inside. It has a humming noise, so that can be disruptive, and it has a canister in there. It sucks all the fluid, and wound vacs in general have been shown to expedite wound healing. So, and the nice thing about that is that for the wound vacs, a nurse comes to your house Monday, Wednesday, Friday to change it, give or take. You don't have to do wound care on those other days. And someone's doing it all for you. So Sid, we were talking about how do we customize wound care? So for someone who doesn't have help at home, who has all those other responsibilities, a wound vac might be a great thing because the nurse can come in to put on the wound vac, take it off, and then the patient doesn't have to worry about doing the wound care by themselves. The problem with the wound vac is it can be very uncomfortable. It has that humming noise, which is very disruptive. Some folks don't want to be connected to a machine, just the whole concept of that. And on top of that, it's a negative pressure suction device. So if you move too much, it has the potential to leak. And when it leaks, it means that air gets into the system and it's not going to function properly. So it can create a lot of anxiety for folks. That can happen underneath the arms, on the buttocks, and areas of creases where you're think of trying to put a piece of tape, because they're basically putting a piece of tape or a sponge on an area of the body. And when you move, it wiggles around. There's probably a good chance that you could develop a leak in that area. So I use wound vacs sporadically for different people, or I also use them in the situation where we start wound care and they're like, you know what, this is just too much for me. well, let's try a wound vac. Let's see how it goes.
Yeah.
That's another reconstructive option. The next reconstructive option is a skin graft. Okay. And skin grafts are something that honestly most surgeons are trained to do. You don't need a plastic surgeon to do that. Although I'm sure the plastic surgeons do a really fantastic job given their focus on cosmesis and so forth. But you can't do a wound vac on the fresh wound. So you still have to go through the process of getting to the point of having that ground beefy looking tissue. I'm a vegetarian, so I'm going to say watermelon tissue.
Thank you. The ground beef is a little rough for
I know, yeah.
Y'all know I'm a baby. Oh my gosh, I prefer watermelon.
All
right, we'll use watermelon. So the watermelony kind of ripply, bumpy red tissue. But you still have to get to that point. So you still have to go through a phase of wound care and or a wound vac to get there. And it involves going back to the operating room for another surgery where you're going to sleep to take a piece of skin from somewhere else on your body. And that is painful. That is very painful. Moving that over to the new area. And it's still cosmetically going to look different than the skin before. So then the decision you have to make is, well, would you rather have a skin graft look and another surgery or a scar look? Okay, so that's kind of the deciding, the decision tree there. So then the other option is a flap. And flaps are great things in general for reconstruction, okay? I have been very leery of flaps for HS. And the reason being is the same thing we talk about why I don't necessarily close wounds primarily, is that you are taking a flap, a piece of skin from one area and you're rotating it up to fill a defect in another area. And as you have all of this systemic inflammation and changes going through your body, it's certainly possible you can develop disease in that area. It's also possible that because of the nature of the tissue there, it's just not going to heal well. And if it breaks down, you actually end up with a bigger wound than you would have had it not just healed from the inside out. Also much more complex, longer surgery. So not saying that it's not the right thing, it's just not the right thing for everyone. So these are the conversations that you want to have with your doctors when you go in to speak with them about surgery as well. And it's hard, it's also hard to have these conversations because doctors unfortunately don't have that much time to spend with patients. I'm fortunate right now because my new patient visits for HS are between 45 minutes to an hour, give or take, and sometimes longer if that's the amount of time that we need to have these conversations so we can go over this. But they used to be a lot shorter, and I found that I just couldn't do that.
That's so amazing. It's like, okay, guys, take your notes from this episode, get your
Yeah.
paper and your pencil ready, have what you need in case, your doctor does happen to have that 15-20 minute slot, but you're kind of getting in a lot of your questions worth asked. So thank you so much for being on. We appreciate you so much. I mean, I'm like, oh my gosh, I could get treatment done. It's not the end of the world.
I told you I'd come take care of you.
Yes.
I'd come take care of her.
She's so amazing. But I can't thank you enough for, the value you brought to my HS journey today and all of the knowledge that I could take back to my community. So thank you so, so much for being on with us.
Oh, it's my pleasure. It's a privilege to be here. Like I said before, it's really humbling. I'm a trauma critical care surgeon by training. And yet when I look back throughout the course of my career so far, I actually get the most sense of purpose out of the HS work that I'm doing, which I recognize a lot of other surgeons they have laughed at me. And that's no disrespect to people with HS, but there's just, I feel great value here in this space. Thank you for, I'm sorry you're going through this, but thank you for taking me along on your journey.
Absolutely.
Yes. Thank you so much. So informative.
Absolutely. So thank you guys so much for joining us on this episode of the Hidradenitis Suppurativas podcast. Thank you to Dr. Goldberg for being here. Super informative. Write down, like Sid said, write down all your notes, take them in with you. Don't be afraid to ask questions. It's a big decision to make this surgery decision. So feel free to ask all the questions, and we'll see you on the next one.
Hidradenitis Suppurativas. If you've got HS, you'll want to meet us. It's not your fault. Put the shame to a halt. HS divas know how to have a ball. The Hidradenitis Suppurativas. Put the shame to a halt, 'cause it's not your fault.